we will be dealing with inguinal canal, rectus sheath, then inguinal ligament, and short answers, inguinal canal, rectus sheath, and inguinal ligament, Hasselbalch's triangle, and spermatic cord. So these are some of the very important topics which will be dealt today. So coming to the essay type of questions, the first question is the inguinal canal. So when this question is usually asked as a long essay question, very important question which you need to know about it. And it is a common clinical thing which we see in the clinical side also. So that is why its detailed anatomy of it is very essential. So this question should be answered under the following headings. That is, you have to say what is inguinal canal, the length and extent of it, then the contents, the boundaries, the defense mechanism, and the applied aspects. So first is definition. So how do we define the inguinal canal? So it is a musculo-aponeurotic canal because both muscles and the aponeurosis of those muscles, they contribute in the formation of the canal. Okay, so inguinal canal. So it is a musculo-aponeurotic canal. So length is about 4 centimeters and it extends from the deep inguinal ring, okay, which is otherwise called as the internal inguinal ring, up to the superficial inguinal ring. So the canal is directed downwards, forwards, and medially, okay, above and parallel to the inguinal ligament. Medial half of this inguinal ligament, you can see this inguinal canal. Okay, so that is the extent. So it is extending from the deep inguinal ring up to the superficial inguinal ring, directed downwards, forwards, and medial. So what are its contents? So contents differs in males and females. Okay, so in females, we will see the round ligament of the uterus. Okay, so you see that this is the round ligament of the uterus, which we can see here, as well as the ilioinguinal nerve. So ilioinguinal nerve, it forms a partial content in the meaning, like it is the content doesn't enter from the deep inguinal ring and traverse the entire canal. Instead, it pierces through the posterior wall of the inguinal canal and then enters the canal. Okay, so that is why it is known as the partial content. In males, we have the spermatic cord. Okay, so spermatic cord will be the content along with the ilioinguinal nerve. So ilioinguinal nerve is a common partial content. In females, it is round ligament. Here it is spermatic cord in males. So that is the content. So coming to the boundaries. The boundaries, it has an outlet and an inlet. So this deep inguinal ring forms the inlet, whereas the superficial inguinal ring forms the outlet. It has a roof, it has a floor, it has anterior wall, and it has the posterior wall. Okay, so these are the boundaries. So we should know what structures forms these boundaries. So to understand it schematically, I put this diagram here. So this is the roof here. Okay, so roof is formed by the arched fibers of the internal oblique muscle, internal oblique and transverse abdominis muscle. Okay, so in this portion, we will have the arched fibers of internal oblique and the transverse abdominis muscle. So that forms the roof of the inguinal canal. Okay, the anterior wall. So anterior wall, if you see from outside to inside, we have the skin, the superficial fascia, and the aponeurosis. Okay, skin, superficial fascia, and the aponeurosis of the external oblique. Okay, so those forms the anterior wall structures. So we have anterior wall formed by the skin, the superficial fascia, okay, as well as the aponeurosis of external oblique muscle. Okay, so they form the wall. So, and medially, we also see the anterior wall that, the lateral 1/3 is also contributed by the internal oblique muscle. Okay, fleshy fibers of internal oblique. Okay, so internal oblique also we will see at the lateral 1/3. Okay, these are the structures forming the anterior wall. So we can see here. So this is the inguinal canal. This is the deep inguinal ring. This is the superficial inguinal ring. So roof here you can see is formed by the arched fibers here. This is the transverse abdominis muscle. This is the internal oblique muscle. So they are forming the roof. Whereas here, the anterior wall, if you see from outside, it will be the skin, superficial fascia. Here you are seeing the aponeurosis of the external oblique. See, this is the external oblique and this is the aponeurosis of it. So that forms the wall, and lateral 1/3 here is this, the anterior wall is also contributed by the internal oblique muscle. Okay, so this is the internal oblique muscle. So that is anterior wall. Okay, so posterior wall. Now, posterior wall, when we say this is the posterior wall. So posterior wall, when we see here, what are the structures which form the posterior wall? So entirely the posterior wall is formed by the fascia transversalis. Okay, so you can see here, it is the fascia transversalis. In the medial half, here in the medial part, medial half, it is contributed by the conjoint tendon. Okay, so conjoint tendon is formed by the transversalis as well as the internal oblique. Okay, the fibers of both join to form the conjoint tendon. Okay, so that is here. So this is the fascia transversalis, and medially we will have the conjoint tendon. Okay, and medial 1/4, this portion, there will be reflected part of the inguinal ligament. So those four structures, they form the posterior wall. Okay, so mainly it is formed by the fascia transversalis. And as we come medially here, half of the medial half of this posterior wall is formed by the conjoint tendon, and medial 1/4 is formed by the reflected part of the inguinal ligament. Okay, reflected part of the inguinal ligament that forms the. Then the floor. This is the floor. So floor is formed by the grooved upper surface of the inguinal ligament. Okay, so the inguinal ligament itself, it grooves like this, like a boat kind of thing. Okay, and that grooved surface forms the floor. So medially, the floor is also formed by the upper surface of the lacunar ligament. Okay, so lacunar ligament, that is actually an extension of the inguinal ligament. Okay, so that also, that forms the floor medially. It also contributes. Okay, so that is then inlet. Inlet here is formed by the deep inguinal ring. So what is this deep inguinal ring? Deep inguinal ring, okay, is a oval gap. So if you see, it is an oval gap in the posterior wall. So posterior wall mainly was formed by the fascia transversalis, right? So it is a oval gap in the fascia transversalis, and it will be lying. So if you see here, okay, so it will be about 1.25 centimeters above the mid-inguinal point. Okay, mid-inguinal point is between the anterior superior iliac spine and the pubic symphysis. Okay, so anterior superior iliac spine and pubic symphysis, if we take pubic symphysis, when we take, okay, the midpoint of it is called as the mid-inguinal point. Mid-inguinal point. Okay, so this deep inguinal ring lies about 1.25 centimeters above the mid-inguinal point. Then we have the superficial inguinal ring. Superficial inguinal ring, if you see, it is in the anterior wall. And anterior wall was mainly formed by the aponeurosis of the external oblique muscle. Okay, so you can see it here. Okay, so it is an oblique triangular gap in the aponeurosis of external oblique. So it is situated above and just lateral to the pubic tubercle. Okay, it will be present. So this superficial inguinal ring, it measures about 2.5 centimeters from the apex to the base. So if you see here, okay, at this point here, okay, so from the apex to the base, it will measure about 2.5 centimeters. And at the base, it will measure about 1.25 centimeters. So that is the superficial ring. Okay, so this is what I already explained to you. So the posterior wall, it is just a revision. That is the conjoint tendon. Okay, so roof is formed by the arched fibers of internal oblique and fascia, transverse abdominis muscle. Okay, floor is formed by the inguinal ligament itself. The grooved surface will form. Okay, so now coming to the defense mechanism. So defense mechanism is very important. Okay. So what do we mean by defense mechanism is, see, the mechanism which prevents the occurrence of or protects against the occurrence of inguinal hernias. Okay, inguinal hernias are common through this inguinal canal. So this defense mechanism protects against the occurrence of inguinal hernias. So what are these defense mechanisms here? So this is very important, which you have to know. Okay. So we have different mechanisms. So we have names for the different mechanisms. So one we call it as slit valve mechanism. Slit valve. Then we have flap valve. Okay, flap valve mechanism. Then we have ball valve mechanism. Okay, then we have shutter mechanism. Okay, slit valve, ball valve, flap valve, shutter mechanism, and then we have the guarding mechanism. Okay. Guarding mechanism. Okay, so these are the different mechanisms. So what do we mean by that? Okay, now slit valve, the first mechanism is slit valve. Slit valve means what happens? See, these mechanisms, so hernias occur whenever there is increased abdominal pressure. So how does this? When there is increased abdominal pressure, now you see the direction of the inguinal canal is downwards, forwards, and medially. Okay, so it is little obliquely placed. So when there is increased abdominal pressure, what happens is the superficial inguinal ring and the deep inguinal ring, okay, because of the pressure and the approximation there, it gets pulled up. Okay. That is it, both the rings, which is like round and the oval shaped and triangular ring, right? Openings, they get pulled up like this. When they get pulled up, it becomes like a slit. Okay, so that is known as slit valve. So they become like a slit and they prevent any structures entering that. Okay, deep. So that is known as slit valve. What do we mean by flap valve? Flap valve is like approximation, flapping, two flaps coming together. So when there is again increased abdominal pressure, the anterior and the posterior wall, they come closer. Okay, so that is known as flap valve mechanism. And next mechanism is the which one? Ball valve mechanism. So what do we mean by ball valve mechanism? So when there is abdominal pressure is increased, right? When the cremaster muscle is nothing but the fibers of the detached fibers of the internal oblique muscle. Okay, so these muscles, they contract. Okay, they contract, and because of that, what happens is the spermatic cord gets pulled up and the testis will come and approximate, it comes and lies against near the superficial inguinal ring. Okay, so like it blocks the passage. So that is known as the ball valve mechanism. Okay, shutter mechanism, like how we pull down the shutter. So the roof is approximated to the floor. So that is known as the shutter mechanism. Okay, so because of the increased abdominal pressure, the roof comes closer to the floor. Next, we have guarding mechanism. So what do we mean by guarding mechanism? So guarding mechanism here is like, now the superficial inguinal ring. Okay, superficial inguinal ring is guarded posteriorly by the posterior wall. So medially, the posterior wall is formed by the conjoint tendon and the reflected part of the inguinal ligament, right? So those two structures, they will help in guarding, means they will reinforce there so that they protect the opening there. Okay, whereas the deep inguinal ring from anteriorly, it is supported by the fibers of the internal oblique muscle. Okay, so like that, they guard the two openings. So this is the defense mechanism. Okay, so these are the things which you need to know. So applied anatomy is, commonly there is occurrence of inguinal hernia. So when the hernia occurs through the abdominal wall and comes out through the superficial inguinal canal, okay, we have what we call it as the direct hernias, and indirect hernias, when we say, they come through the deep inguinal ring. Okay, so deep inguinal ring. So that is known as the indirect hernia. So you should know the difference between the indirect hernias and direct hernias. Okay, so indirect hernia usually occurs through the deep inguinal ring, and it is usually congenital. Okay, whereas the direct hernias, they occur through the Hasselbalch's. Later, I'll be telling you about Hasselbalch's triangle. So they occur through that Hasselbalch's. That is through the anterior abdominal wall. It will come. It doesn't enter the deep inguinal ring. Okay. So that occurs, that is congenital, but here it is acquired. Basically, due to muscle weakness, it is seen. Okay. In adults, especially those who carry heavy weights, their abdominal muscles have become weak. We can see this. Direct hernia. Indirect inguinal hernia has to be corrected immediately. Okay. Whereas direct hernias, we can wait. Okay. They are not very to be attended very urgently. Okay. But whereas indirect hernia needs to be. So there basically the pathology there is patent processus vaginalis, which is responsible for the descent of the testes. So that process vaginalis will remain there. So because of that, the deep inguinal ring, through the deep inguinal ring, the hernia occurs. Okay. So this is the difference between indirect and direct inguinal hernias. So when we write about inguinal canal, so when we summarize, okay, so what are the things which we need to know is, okay, inguinal canal. Okay, so first is definition. So it is a musculo-aponeurotic canal. Then you will write how long it is, 4 centimeters, extending from where to where? From the deep inguinal ring. Okay, deep inguinal ring to the superficial inguinal ring. Okay, then you will mention the contents of it. Okay, so both in males and females, what are the contents? Then talk about the boundaries. So boundaries will include the roof, floor, the walls, which include both anterior and posterior wall, okay, and the openings, which form the inlet and outlet, okay. Then you talk about the defense mechanism, and where we have those 5 mechanisms: slit valve, ball valve, flap valve mechanism, and then we have strutter mechanism and guarding mechanism. Okay. Then after that, you talk about the inguinal hernias. That is the applied aspect. So these are the things which you need to write in under inguinal canal. Okay. So this is the next is rectus sheath. So next important question asked is the rectus sheath there. Okay, in the anterior abdominal wall. So what is we mean by rectus sheath? So here again, when this question is asked, you need to talk about its definition, the location, features, formation, contents, applied aspect. So first is definition. What do we mean by rectus sheath? So rectus sheath, when we say, it is an aponeurotic envelope for the rectus, okay, or it is an aponeurotic covering for the rectus abdomen. This is the rectus abdominis muscle which we are seeing here. And this is the rectus sheath, okay, which is open here. So this rectus sheath is a aponeurotic sheath enclosing the rectus abdominis muscle on each side. So the center thing, what we see here is the linea alba. So there is a pair of rectus abdominis muscle. So it will be covering this rectus abdominis on each side of the linea alba. Okay, so that is the thing. So what is its, so it is situated in the anterior abdominal wall. So why it is important? Why this rectus sheath is important? Okay, what is its feature or function there? So it acts as a retinaculum, means it will, how we have in the limbs, lower limb, upper limb, we have the retinaculum holding all these tendons in place, so that when we move the wrist or when we flex the wrist and all, so there is no bowstringing. Bowstring in the sense the tendons don't form like a bow, or they don't form like a loop, because it is loosely arranged there. Okay, so that is why this retinaculum will hold it tightly so that they don't move there. Same way here also, what happens is this aponeurosis, it will prevent, okay, it will act like a retinaculum and prevents the muscle from bowstringing. Okay. See, in abdomen, we do not have the deep fascia to provide any strength there. Okay. Instead, these aponeurosis sheets, whatever is present there, will be providing the strength for these muscles. Okay. So next is the formation when we talk about. Okay. So features and formation when we talk about. So here, the sheath is formed by the splitting of the aponeurosis of the internal oblique, as well as contributed by the aponeurosis of all the three muscles there of the anterior abdominal wall. We know that we have three muscles there mainly, that is the internal oblique, external oblique, internal oblique, and transverse abdominis muscle. So the aponeurosis of all these muscles, they contribute to the formation of this rectus sheath. Okay. So we will see how it is formed. So now this rectus sheath, if you see, it will have an anterior wall. So this is the anterior wall. Behind this here, okay, this is the rectus muscle. So behind that rectus muscle will be the posterior wall. And it will have a medial margin and a lateral margin. Okay. So here, the medial margin, what is formed here, it is formed by the linea alba. So what is this linea alba? Linea alba is formed by the interlacing of all the aponeurosis, okay, of the three flat muscles, that is external oblique, internal oblique, and transverse abdominis muscle. So all the three aponeurosis will join together to form this linea alba. Whereas the lateral margin here, okay, the lateral margin, what is there of the rectus sheath, is called as the linea seminonaris. Okay, so linea seminonaris. So it will be extending from the tip of the ninth costal cartilage up to the pubic tubercle down. Okay, so that will be the linea semilunaris. Okay, semilunaris. So that is the lateral wall. So we will come to the anterior wall now. Okay, so this anterior wall, when we see here of the rectus sheath, it is complete. It is complete, okay? And is made entirely by the fibrous tissue. Okay, but the thing is, it will differ in the upper part. So if you see, it is there, but it will differ in the upper part, in the middle part, and in the lower part. So which parts it will differ, we will see. So how we will demarcate. So one thing is, we will take different levels. So one level we take is at the above the costal margin. Now, this is the costal margin. Okay, so above the costal margin now, okay, the costal margin here, the anterior wall, what happens is it is very thin. Okay, now why it is thin here? Because the anterior wall is contributed by only by the aponeurosis of external oblique. Okay, so it will be thin. So this will be above the costal margin. Okay, so above the costal margin, we will see it like that. So from the costal margin and midway between the umbilicus, okay, and the pubic symphysis, that is near this, this is the arcuate line. So just up to that arcuate line, okay. So that here it will be thick, okay, it is thick. So why it is thick is because here it is formed by the aponeurosis of external oblique and the internal oblique, anterior lamina of the aponeurosis of internal oblique. Internal oblique aponeurosis, what happens is it splits to enclose, unlike this external or transverse muscle, okay, aponeurosis. So here the anterior wall is formed by the aponeurosis of external oblique and the anterior lamina of the internal oblique muscle. Okay, so since two aponeurosis are contributing there, it is thicker. So this is where between the costal margin and the arcuate line. Okay, so below the arcuate line. So below the arcuate line, what happens is it is very thick. Okay, it is very thick because here all the three, that is external oblique, internal oblique, as well as the transverse abdominis muscle, all the three will contribute to the formation. Okay. Understand? So external oblique, the anterior lamina of the internal oblique, as well as the transverse abdominis aponeurosis, all will contribute to the formation of the aponeurosis. So it is thick. So this is the anterior wall. Now coming to the posterior wall, we will see it like the same way. So above the costal margin. So this is the costal margin. No? So above the costal margin, what happens? You are not seeing anything here. This is rectus abdominis. This is lying directly lying on this costal margins and muscles here, fascia covering these muscles here. So, okay. So, here it is deficient. Okay. So, here it is deficient above the costal margin, and the muscle directly rests on the 5th, 6th, and 7th costal cartilages. Okay. So, this is where in the above the costal margin. Next, we have the middle part, that is between the costal margin and the arcuate line. Okay, so here what happens, the wall is composed, here it is made up of the lamina of, it is fibrous here, and it is made up of the posterior lamina of the internal oblique muscle and the transverse aponeurosis of the transverse abdominis muscle. Okay, so they both will contribute. And the lower extent of that wall, no, that is the posterior wall, will form what we call it as the arcuate line. So you can see here, that is the lower extent of the wall. Now, below this arcuate line, what happens? Again, the wall is deficient. Which wall is deficient? The posterior wall is deficient. Okay, the posterior wall is deficient here, and the rectus muscle is covered actually by the transversalis fascia. Okay, this dotted line is transversalis fascia. So it will be covered by the transversalis fascia. Okay, so this is very important, formation of the rectus sheath. Next, we will see. So this is the same thing. So above our arcuate line, you can see on either side how it is contributed by. Okay, so here the wall is formed, anterior as well as posterior wall is formed. So in the middle part, that is between the costal margin and arcuate line, the anterior as well as posterior wall is very well defined. Okay. So what are the contents? Now contents here, muscles. Muscles are two muscles. One will be the rectus abdominis muscle. Another muscle will be the, which one? The pyramidalis. Pyramidalis is the inconsistent muscle. It may or may not be present in everyone, but that is also the muscle which is present, rectus abdominis and pyramidalis. Then vessels. Vessels, we have inferior epigastric and the superior epigastric vessels. Okay. So muscles, so we will write it as contents. Muscles. Okay. Muscles which include rectus, abdominis and pyramidalis muscle. Then we have vessels which include superior and inferior epigastric. Okay, epivessels include both arteries and veins. Then we have the third one will be the nerves. Okay, so nerves, what do we have here? We have the lower 5 intercostal nerves and the subcostal nerve. Okay, so T7, T8, T9, T10 and T11. T12 is known as the subcostal nerve. Okay, so the lower 5 intercostal nerves and the subcostal nerve you can see in this within the rectus sheath. The subcostal nerve supplies the pyramidalis, okay, in addition to the rectus abdominis muscle. So you can see them. Okay, so basically they pierce through this, through the posterior wall of the sheath and they will supply. Okay, then they become, through the anterior wall, they will supply the muscle, then pierce the anterior wall and become cutaneous. So why this rectus sheath is important is, okay, so okay. So diverification of the, so usually see in the linea alba, the muscles are very closely arranged there. Okay. So sometimes what happens is it becomes very loose there. Okay. And there is the gap created, diverification of the recti, we say. Okay. Recti muscles. So the rectus abdominis, that is basically because of the weakness of the aponeurotic sheath here. This becomes weak and the muscles are separate. Okay. Means they go away. They do not provide enough strength to the anterior abdominal wall. And epigastric hernias are very common in this region when there is weakness of the wall. Okay, so see, normally we see it like this. This is very in obese people and all because of excessive stretching. Okay, it becomes weak and it results in this condition. Since there are vessels present within the, that is the superior and inferior epigastric vessels are there, right? So some trauma to the abdomen, okay, blunt trauma can cause hematoma of the rectus sheath. Okay, epigastric hernias are more common, basically because of the weakness, and also when there is linear incision is given for any surgery. If the incision is done along the linea alba, what happens is, since it is a connective tissue, aponeurosis is a dense connective tissue, right? So it doesn't heal properly, and there is always a weakness, that tensile strength is not regained back. So because of that weakness, any pressure will cause protrusion of the structures and results in the hernia there. So these are the things which you need to write. Okay, so rectus sheath. What is rectus sheath? So it is an upper, so the definition, rectus sheath. The definition that it is an aponeurotic sheath. Okay, then you write about its formation, function. Okay, so when you write about formation, you tell its boundaries also. Okay, and mention the formation boundaries, that is walls and margins. Okay, then function, why it is important. It acts as a reticulum and prevents the bowstringing of the muscle. And then we write about the contents, what is present. So where it includes 2 muscles, 2 vessels, and 2 nerves. Nerves in the sense, the 5 intercostal, okay, 5 lower intercostal nerves, posterior intercostal nerves, and subcostal nerve. Okay, subcostal nerve. So this will be the contents you will talk about, and then you will write about the applied aspects. Okay, applied aspects. So always in anatomy, you have to write about the clinical aspects. Okay, so as to correlate why you need to know the anatomy. So this is the summary. Always learn the answers, giving the headings. So coming to the short questions, we have first is the inguinal ligament. Okay, so inguinal ligament. So what is inguinal ligament? Okay, the definition and the attachment you need to understand. Okay, so inguinal ligament. Inguinal ligament, otherwise it's also called as Poupart's ligament. P-O-U-P-A-R-T-S. Okay, Poupart's ligament. Okay, Poupart's ligament means also inguinal ligament. So this is actually, it is the thickened lower border of the external oblique muscle aponeurosis. So aponeurosis of the external oblique muscle, no? See, external oblique muscle will be attached here to the outer lip. So this portion, it is free, right? So here what happens is, it becomes, the lower margin of that, it becomes thick. Okay, and that forms the inguinal ligament. So basically it is the thickened lower end of the lower border of the external oblique muscle aponeurosis. Okay, so it measures about 12 to 14 centimeters in length. So it extends from the anterior superior iliac spine up to the pubic tubercle. Okay, up to the pubic tubercle. So midpoint between the anterior superior iliac spine and the pubic tubercle is called as the midpoint of the inguinal ligament, whereas midpoint between anterior superior iliac spine and pubic symphysis is known as mid-inguinal point. So where we had the deep inguinal ring about 1.25 centimeters above that, isn't it? So that is the thing. So this inguinal ligament, the modifications, we see some of the modifications there of this inguinal ligament. So you can see here, okay, 3 things we see. One is the lacunar ligament. Another one is the reflected part of the inguinal ligament and pectineal ligament of Cooper. Okay, so this is the pectineal ligament of Cooper. So these 3 structures are the expansions or modifications of inguinal ligament. So lacunar ligament, this is the lacunar ligament. So lacunar ligament was also reinforcing the posterior wall, isn't it, of the inguinal canal. So this lacunar ligament, no, it is a triangle in shape. Okay, it's triangular in shape. So you can see it's triangular in shape, and it extends backwards and slightly upwards. Okay, from the inguinal ligament. So this is the inguinal ligament, backwards and upwards. It goes like this. Okay, so it is apex of it, it is formed by the pubic tubercle here. And the base here is free. Okay, concave and forms the medial boundary of the femoral canal. Okay, so lacunar ligament forms the medial boundary of the femoral canal. That is the medial compartment of the femoral sheath. We call it as femoral canal, right? So there it forms the medial boundary. So this is the lacunar ligament. Okay, then we have the reflected part of the inguinal ligament. Okay, this is the reflected part. Here you can see. So few fibers, okay, of the from the inferior crest of the superficial inguinal ligament. So superficial inguinal opening is from what? From the external oblique muscle. It's an aponeurosis, isn't it? So here they are reflected upwards and medially towards the linea alba, and they are attached to the linea alba. So that portion is known as the reflected part of the inguinal ligament. Okay. Then we have third thing is the pectineal ligament. So from this base of this lacunar ligament, a fibrous band will extend like this, okay, and it is attached laterally to the pecten pubis. Okay, so pecten pubis. Now this is the bone here. Pecten pubis will be the superior. This is the superior ramus. This is the body of the pubic bone. This is the superior ramus. This is the inferior ramus. Okay, so the superior surface of the superior ramus, no, of the pubic bone, we call it as the pecten pubis. Right, so it will be attached to the pecten pubis on up to the ilio. Pubic eminence, iliopubic eminence will be up here. Okay, this will be the iliopubic eminence here because this is the pubic bone, this is the ilium. Right. So what are the structures which will be attached here for the inguinal ligament? So from lateral two-thirds, we will have the lateral two-thirds. We have the origin of the internal oblique muscle. Lateral one-third, we have the origin of transverse abdominis muscle. Okay. And from the middle one-third of it, the cremaster muscle in males. We see, okay, cremaster muscle. That is the detached fibers of the lower fibers of the internal oblique muscle. We see that there. Okay. So this is the thing. And the lower surface of this inguinal ligament gives this thing to the, what is that? Attachment to the fascia lata. Okay. So these are the things. So inguinal ligament. So what is it? Okay. So what will you write? Inguinal ligament. First, what is it? Always the definition. What is it? Where it is? Okay. So it is the thickened part of the lower border of external oblique muscle. Aponeurosis, external oblique aponeurosis. Okay. So that is there. So it is about 12 to 14 centimeters in length and extends from the anterior superior iliac spine to pubic tubercle. Okay. So pubic tubercle, it extends. Right. Then you talk about its modifications or expansions. Okay, so what are those? We have Gubernard's lacunar ligaments, a Gubernard's ligament, lacunar ligament. Then we have reflected part of inguinal ligament. And third thing we have is the pectineal ligament. Pectineal ligament of Cooper. Okay, so while this inguinal ligament, it forms an important landmark there. Okay, below that, the fascia lata is also attached. No, to that, it gives origin to muscles. Okay, muscles are internal oblique muscle. Then we have the transverse abdominis muscle. Okay, they're all attached, originating from there, from the inguinal ligament. And structures are passing beneath the inguinal ligament also, like femoral artery, femoral vein. Okay, then there is lateral cutaneous nerve of thigh, which will enter. So sometimes because of compression, it can cause symptoms, okay, tingling and sensations along the lateral aspect of the thigh. So all this you write under the applied aspects. Next question is Hasselbalch's triangle. So Hasselbalch's triangle. So what is it? Okay. So what do we mean by Hasselbalch's triangle? So Hasselbalch's triangle, if you see, it is a triangular area. Where do you see it? We see it in the this thing, that is the peritoneal wall of the anterior abdominal wall. Okay, so this is seen in the peritoneum. So it is a peritoneal triangle in the posterior wall of the inguinal canal. Okay, up here you will see. So if you see how you will write the answer. So what's the definition? Its location, boundaries, and clinical importance. So basically it is a peritoneal triangle. Okay, where it is located in the posterior wall of the inguinal canal. Boundaries, it is bounded. Okay, so it has a medial boundary, a lateral boundary, and the base. So medially, it is formed by the lateral border of the rectus abdominis. Okay, and medially, laterally, it is formed by the inferior epigastric artery, that is vessels, and below by the inguinal ligament. Okay, so what is the importance of this Hasselbalch's triangle? So direct hernias. Okay, so the direct hernias enter the superficial inguinal ring through this Hasselbalch's triangle. Indirect hernias come outside the Hasselbalch's triangle. Okay, direct hernias come through the Hasselbalch's triangle. So that is the importance there. Okay, so here if you see, no, this is the peritoneum, that is the parietal layer of the peritoneum. So parietal layer of the peritoneum, down here you will see folds. So this is the medial umbilical fold, okay, which is otherwise called as the which is formed by the urachus, median umbilical ligament. Okay, and next to that there will be two more folds, that is medial and lateral. So medial umbilical fold will have the obliterated umbilical artery, and the lateral umbilical fold will have the inferior epigastric artery. So this whole thing, okay, up to here will be the Hasselbalch's triangle, which includes both these spaces. Okay, so if the hernia occurs medial to this medial umbilical fold, it is medial direct hernia. If it occurs lateral to this medial umbilical fold, it is lateral direct hernia. Okay, so that is one more thing which you need to remember. So that is the importance of Hasselbalch's triangle. So you can see it very clearly how it is formed. Okay. Okay, so these are the things which you will write. The last question, spermatic cord. So spermatic cord should be answered under these headings: definition, extent, coverings, contents, and applied aspects. Okay, right. So, so spermatic cord is what now? Spermatic cord is formed by the, what is that? What is spermatic cord? Spermatic cord now, it is basically, it suspends the testis, isn't it? So spermatic cord is actually, what happens is the testis, okay, spermatic cord will form what is that, canal for many of the structures, testicular structures which pass through that. Okay, so this spermatic cord, it will enter like, through the deep inguinal ring, it will enter. So you will see this spermatic cord coming there, right? So now this spermatic cord is covered by many coverings. So what are those coverings now? Okay, so coverings, when we say from inside to outside. Okay, so first covering, so it is entering through the deep inguinal ring here. So what coverings we will see? First covering, what we see will be the internal spermatic fascia. So internal spermatic fascia is formed by the continuation, the deep inguinal ring itself. Okay, it will continue inside, okay, as the internal spermatic fascia. Okay, the rims of that deep inguinal ring, okay, it extend inside as the, so you can see here, deep inguinal ring is the opening in the fascia transversalis. So it is extending inside as the internal spermatic fascia. Then we have the next will be the, upon you, this one, what is that? Internal oblique. Okay, so internal oblique, there we'll see the cremasteric muscle and the fascia. Okay, so the cremasteric fascia will be the next covering, because from internal oblique we'll have the cremasteric muscle. The detached fibers will have cremasteric muscle, and the fascia covering that will be the cremasteric fascia. So you will see the cremasteric fascia. Then from the external oblique muscle, we'll have the external spermatic fascia continuation. Okay, so these forms the coverings of the spermatic cord. So what are the contents of the spermatic cord? So main content, testicular artery and pampiniform plexus of veins. Okay. So pampiniform plexus of veins are a bundle of veins which are present around the testicular artery. Then we have remnants of processus vaginalis. We have the vas deferens. Okay. We have the artery of the vas deferens. Okay. Artery of the vas deferens. Then this thing, autonomic nerves, we have connective tissue will be present within that, lymphatics and connective tissue. Genital branch of genitofemoral nerve will be present between the cremasteric fascia and the external spermatic fascia. Then cremasteric artery and fascia, cremasteric veins will be present. Okay. So these will be the main contents within the spermatic cord. It is a very commonly asked question. Okay. So what do we see? Varicocele is more common here because of the pressure. Okay, so varicocele is the dilatation of the pampiniform plexus of veins, which we see. Okay, so basically, we see to maintain the artery pressure will be high. Okay, which will be supplying the testis. So testis is first of all outside the body within the scrotum, so as to maintain its ideal temperature for spermatogenesis. So this arterial pressure shouldn't be high and it should not be warm, that is higher temperature, right? So to decrease this pressure and temperature, we have these veins, a group of veins surrounding the artery there, okay? So as we go up to the superficial inguinal ring, this pampiniform plexus, they reduce to 4 veins, and at the deep, they form 2, and then they form 1, like that they reduce, and then finally they form 1 testicular vein. And on the right side, it drains into the inferior vena cava, and on the left side, it drains into the left renal vein at right angles. Okay. So usually this varicocele, we see it on the left side, basically because there the left testicular vein, it is at right angles opening into the left renal vein. And second thing, what happens is there sometimes because of chronically constipated patients, pressure of the sigmoid colon, loaded sigmoid colon over this artery causes pressure, and that leads to varicocele formation. So that is one common condition which we see. If this condition, so you can see the varicosity of these veins here. If this condition, if it is not corrected, it can lead to infertility. Okay, it's a very common thing. So these are the things you will write. So spermatic cord, what is it? So basically it forms a facial covering. Okay, spermatic cord forms a facial covering for the testicular structures. So you will write the coverings of it. Okay, then you write the contents of it and you write about the applied aspects mainly. Okay, and one more applied aspects what we can write is we approach through that actually spermatic cord during vasectomy surgery. Vasectomy surgery, what happens is we do not go up to above, whereas before the vas enters the spermatic cord. So before that only we do the surgery where the vas is cut. Okay. So vas deferens is dissected there. Okay. So these are the things which you will write. And with this we complete. So thanks for watching. So you can download the app, Auricle app on Google Play or App Store. And you can follow the contents on the social media handles. So we are on YouTube, Instagram, Facebook, as well as Telegram. So until next, bye.